Okay, so this training is a joint project which is sponsored by the Union and the 5 CDC-funded regional training and medical consultation centers. So we wanted to say thank you to NTCA and to the Union and NAR for including this postgraduate course on epidemiology in the conference. And I did want to share that NTCA has made it possible for this whole training to be recorded, and the recorded sessions will be available freely to anyone who's interested after the fact. So we're really excited about that, and we will send an email to communicate how to access the recordings. Okay, I think most of you are already familiar with the Union since we are here at the NAR conference. Soon you'll be hearing more about Vital Strategies, which is a newer part of the Union. And as many of you also know, these are the areas of coverage for the 5 tuberculosis RTMCCs. All of the RTMCCs provide training, educational products, technical assistance, and medical consultation. This map shows the regions for the different RTMCCs, and I always like to ensure everyone knows that each RTMCC offers webinar trainings as well as products, and those are available for a national audience. Those are not for the regions. They're available to everyone. So on behalf of the Union and the RTMCC joint sponsors for today's training, we'd like to thank all of today's presenters, as well as the members of the planning committee for this course. And the slide is not advancing for me. Thank you. So all of our faculty members and planning committee members have completed a declaration of disclosure and do not have anything to disclose. This training is approved for 3.5 continuing education contact hours, and partial credit will not be able to be awarded. In order to receive your continuing education hours, you must register from NTCA and NAR, sign in, and we do have a sign-in sheet that's going around the room, attend the entire training, of course, and complete the online evaluation. So the RTMCC based in Florida is managing the evaluation for this training. It's an online evaluation, and I'm going to show you where to find that website in just a moment. So many of you may have received an email from me last week letting you know how to access the training materials. All of them are available in the PDF handout format online on this website. And this URL is also printed on the bottom of the agendas, which are being handed out in the back of the room. So if you don't have this URL, please make sure you see Lori back there, and she can, there's Lori, thank you. She can provide you with that. And this is the URL for the training evaluation. So when you go to the materials website, there's a credit page, and this URL is present on that credit page. So the easiest thing to do is probably just go to the credit page and click this after the training to complete the evaluation. We do ask that you complete the evaluation by March 2nd. And we will be following up with you in about 4 months after the training to assess some of the impact of today's event. So now I'd like to turn things over to Dr. Lisa Pascapella. She's going to be facilitating today's training, and Dr. Pascapella is a senior epidemiologist at the California Department of Public Health, TB Control Branch. She's also president-elect of the Society for Epidemiology and TB Control, and in the past, she was working with us over at the Curry Center. So thank you, Lisa. I'll turn things over to you.
Thank you, Kelly, and thank you to all the RTMCC staff and NAR and Union staff that helped put this together. And special thanks to the NTCA, Jennifer Knaus and Donna Wegner, for finding a way to, on very short instructions, to actually record this session. So my role today is to facilitate this wonderful program. and I'm really pleased to see you all here. And we have a packed schedule, but we also have time after a series of 3 and 2 speakers in each section for questions and answers. And so after the first 3 speakers, we'll have a Q&A session for about 10 minutes. We'll then have a break, and I am assured that we will have coffee at that break. There will then be 2 speakers with another Q&A session, and the last 2 speakers with the Q&A session, and then I will wrap up. So without any further statements from me, I'm going to introduce our first speaker, Dr. Shama Ahuja, who is the current president of the Society of Epidemiology and TB Control and the director of TB Surveillance and Epidemiology at New York City's Department of Public Health.
Good afternoon. Thank you for coming, and thank you for the organizers for having me here. It's been really gratifying to be part of the planning committee for a training like this. I think it's really important for there to be opportunities for everybody in TB control to think more broadly about applications of epidemiology in TB control, and so I'm really excited to talk about that and help sort of introduce the day. So I'm going to talk primarily, I'm going to just do a quick review of the key activities in TB control globally, nationally, and locally. And then I'm going to talk a little bit about how epidemiology is currently used in US-based TB programs. And then I'm going to take the liberty of giving some examples from New York City, since that's where I work, and really talk about how we make a concerted effort to really use data strategically. So key activities in TB control. So a lot of this will be review for people, I hope, but since this is an international conference, I wanted to make sure and start with sort of the global perspective. As we all know, WHO has a Stop TB strategy, and I'm not going to spend a lot of time on it, but I just wanted to quickly go over the components of the Stop TB strategy, which is to pursue high-quality DOTS expansion and enhancement, address TB, HIV, MDR, and the needs of the poor and vulnerable populations, contribute to health system strengthening based on primary health care, and to engage all care providers. Also, to empower people with TB in communities through partnership, and to enable and promote research. And I kind of think it's very interesting for us, from a U.S. TB control perspective, to remember the global strategy, because I think we can continue to learn from it. More recently, the WHO has put out an End TB strategy, and it's really based on 3 pillars, and those are integrated patient-centered care and prevention, bold policies and supportive systems, and intensified research and innovation. And I just wanted to sort of point out the areas where I think epidemiology can particularly contribute in these pillars. So in terms of systematic screening of contacts and high-risk groups, in terms of engagement of communities and targeting priority populations, as well as case notification, as well as vital registration, and then of course research. Then I wanted to switch gears and talk a little bit about the US example, the national perspective. Back in 1995, a document was put out in the MMWR about essential components of TB prevention and control programs by the Advisory Council for the Elimination of TB. And this document is being rewritten right now, but, I just wanted to quickly just point out the core components of what was recommended, because I think it's still pretty relevant. Conducting overall planning and development of policy, identifying persons who have clinically active TB, managing persons who have or who are suspected of having disease, identifying and managing persons infected with MTB, providing laboratory and diagnostic services, as well as collecting and analyzing data and providing training and education. The CDC also funds TB programs across the U.S. Through cooperative agreements, and they have put out these sort of basic principles for TB control, which include find, treating, and case managing TB cases to treatment completion, contact evaluation, prevention of TB disease in persons with TB infection, and prevention of recent transmission through application of infection control measures as well as molecular epidemiology. Programs are funded specifically to conduct surveillance and reporting, treatment and case management, contact evaluation, evaluation of immigrants and refugees, program evaluation, and human resource development. And I've highlighted here the specific areas that where epidemiology can have a specific contribution. Then at the local level, I'm giving the New York City example of key activities that are conducted on the ground. In New York City, our primary activities are direct patient care. We have clinics around our city that provide care for TB patients. We also have surveillance and reporting, case management, contact investigation, outbreak detection and response, medical consultation and outreach, and research and evaluation. And in our program, surveillance and epidemiology has a key role in a number of these areas. And the reason that I did this sort of demonstration is just to kind of point out that epidemiology is more than case rates and, figures that can show sort of what the numbers look like. That is certainly one component, and it's an important one. But there are also a lot of other ways that we can be applying epidemiology in our work day to day. So I am also the president of the Society for Epidemiology and TB Control, and I'm not going to go through all of our guiding principles, but I did want to let you know that we have them and that we are a professional network of TB controllers, TB control staff who are interested in epidemiology. So we welcome non-epidemiologists as well into our section, but we do sort of have these guiding principles that guide what we do. And I wanted to take the opportunity of using our membership to give you all a sense of how epidemiologists are being used across the country. Now, we have a sad sample response rate for our member profiles, but we're trying to improve that. We did a raffle today for a Starbucks gift card, so hopefully we'll have more completion of our member profiles. But of the 43 people who did answer our membership directory, our membership profile, you see that the vast majority of people are working on surveillance, analysis, and data management. A lot of what you would, typically expect for people working in epidemiology. But you also see that there are our epidemiologists are working on cluster and outbreak investigations, field epidemiology and expanded contact investigations, database design, survey design, research and study design, genotyping, and informatics. So I was really gratified to see that there was really a broad application of what epidemiologists are doing around the country. So that's basically what I just said. But in terms of thinking about broadening even further, I think that there is a role in terms of enhancing field investigations, whether it's assessing transmission in a contact investigation or conducting an outbreak investigation, where epidemiologists can really provide a lot of the expertise needed to coordinate and conduct and see those investigations through to completion. Also, using surveillance data to inform and evaluate program planning, I think, is a key role that we have, particularly as it pertains to identification of high-risk groups. And I also think that we have a role in terms of informing non-epidemiologic analyses. So increasingly, we're hearing about things like cost-effective analyses, as well as qualitative studies, needs assessments, and things like that, which really are an extension of the data that we currently collect and thinking about how to contribute to those analyses as well. I have no idea how to time. Is there a time thing? Okay, great. Okay, so the New York City example. So we have a lot of data in New York City that we have access to, and we are go through a lot of sort of quality checks and to make sure that our data is usable not only for TB control activities and case management, but also for analyses. The data comes from a variety of places. Our patients are reported to us at the health department. All TB cases are assigned a case manager, and then a chart review. Those case managers conduct chart reviews and interview patients and identify contacts, and then those contacts are interviewed and then tested. And then we follow up all cases and contacts to the end of treatment completion. And at every step of this sort of case management process, we are collecting data, lots and lots of data. So we put our data in a system called Maven, and we collect data not only on TB cases, but also on contacts to TB cases, as well as persons suspected of having TB, and children under 5 years old with who have a positive test for TB infection. We have over 2,000 variables in Maven in 19 different groups, question packages or groups of questions. So we collect a tremendous amount of information, and this data is really sort of the backbone of the work that we do at the health department, and it's integrated in all of our public health response activities. We really try to use this data strategically in a number of different ways, and I just wanted to provide some examples. So surveillance or case management data is used to review trends, to understand our local epidemiology. It's obviously critical. We all work in different settings, and it's extremely important to know what's happening locally. So you can plan appropriately. We also monitor certain high-risk groups and certain high-risk populations. We inform decisions on when to expand our contact investigations, and we also do ad hoc analyses to inform policy and programmatic decision-making. We use our genotyping data to do active surveillance of TB strains in New York City so that we understand what strains might be circulating, and when we can identify a new strain when it's entered our population. We also use genotyping surveillance to detect outbreaks, and then we inform epidemiologic investigation to better understand the TB transmission dynamics in New York City. Finally, we use our data for research and program evaluation work, and this is really to inform our clinical care and practice, as well as hopefully national and international policy as well. Within our bureau, almost every time I talk to another program, they ask me how we're organized. So for those purposes, I kind of thought it would be helpful to have just a quick review of how our surveillance and epidemiology office is organized. We have 4 primary responsibilities. We do surveillance, which is provider and lab reporting, data collection and data entry, maintaining our case management system, and which manages electronic reports and laboratory information. We do laboratory coordination, working with a number of different labs to get the results that we need, and also manage interstate referrals. In terms of field epidemiology, we conduct surveillance for and investigate exposures of TB in congregate settings to identify and prevent transmission. So that's doing investigations at schools or work sites around the city, as well as doing outbreak detection and response work, which includes looking at our genotyping results, looking at clusters, and all of the related information, using that to identify and prioritize and assign our clusters for investigation, coordinate any public health intervention that might be needed to respond to the outbreaks that we identify, and then also to try to control them if we can. And then finally, we use we have a epidemiologic data analysis and research group, and when I say group, I really mean like one person for like each of these. But it seems like a group because we try to get a lot done. We monitor trends, descriptive, and looking at descriptive and analytic studies to guide our program and clinical care. Okay, so this is what our numbers look like. Everybody, I think most people are aware of the outbreaks that occurred in the 90s, and we've had a lot of success in TB control since then. We are down to about 550 cases or so a year. As you can see, we're kind of plateauing, and it seems like we're mostly doing a pretty good job. But then when you kind of focus in on the orange line, you'll see that's our overall New York City rate. But when you look more closely at the US-born and foreign-born, you see that most of the TB control that we've achieved is really in the US-born population. And the foreign-born population has remained pretty steady back since 1997 when foreign-born cases outnumbered our US-born cases. So overall, we've seen an average decline in TB cases of about 8%, and in the US-born, we've seen about a 15% decline each year. On the foreign-born, we've only seen about a 0.6% decline. And I'm showing you some of this data mostly to just, show you kind of examples of how to use surveillance data to just basic surveillance data, nothing complicated. We use this information when we talk about sort of our two epidemics. Then the sort of next step is really to think about how can we use this information to prioritize. So when we think about priorities for TB control, we're primarily focused on recent transmission. So what you see in the red box, we spend a lot of time on contact investigation, and we want to make sure that contacts are evaluated and tested. We also focus on clustered cases and outbreak cases, of course, and then any TB that we might see in young children. Then our sort of next group that we're concerned about is the high-risk groups, which could be people with HIV or other medical risk factors for TB, and then sort of marginalized populations, such as the homeless population, substance users, and undocumented persons. And the way that we're kind of trying to use our data more is to understand who else is at risk. I mean, these are all sort of the established groups that we know well, but who in the foreign-born really needs to be a priority. We live in a city of 8 million, almost 8.5 million people, and 30% of them are foreign-born. So to think about really targeting the entire foreign-born population we don't have the resources to do that. So we really have to use our data to try to think about what groups would be best to focus on. Also, other medical risk factors, that's something that is it's harder data to get, but we need to get better information on other medical risk factors because we do think that there's some confluence of being foreign-born along with additional medical risk factors that we really need to focus on and need better data for. We use our data to try to identify high-risk groups through these primary ways, which is routine data analysis. We put out a very lovely annual report. Natalie, who's in the audience, and Jean work very hard on that, along with Lisa True in our office, to really put a very rigorous report together that provides a lot of information that is really used by our program every year to guide our programmatic decisions. We also do supplemental data analyses. We try to monitor sentinel populations, some of the high-risk groups populations that I just mentioned. And then, of course, we do ad hoc analyses when we notice something weird's going on. Then, of course, we try to participate in research and conduct our own research whenever we have time to. And then we use our molecular epidemiologic data as well. This is just an example. I'm not sure why there's a piece out of Mexico. Please ignore that. But this is just an example of how we've used our surveillance data to think about prioritizing foreign-born populations and high-risk groups. So what you're looking at is the median years in the U.S. And the proportion of clustering that we're seeing among New York City cases. And then the line, sorry, hold on. Okay, so this line is just to tell you overall in New York City, 35% of our cases cluster. But in the U.S.-born, in the foreign-born population. In the U.S.-born population, 65% of our cases cluster. And then you see the circles represent the size of the population for each of the different foreign-born groups. So we have many, many, many different countries of origin represented in our patient population. It can be as many as 60 countries in a year. And this is several years of data together. But the way that we're using this information or have used this information is to try to prioritize basically this quadrant of recent arrivers who are more likely to cluster. And so we've tried to focus some of our community outreach efforts on this group. We also have had to focus on the Chinese population just because we've seen some outbreaks in that population as well as a tremendous burden of disease. China outnumbers US-born patients in New York City for the past couple of years. So anyway, this is just to give you an example of how you can use pretty straightforward data that many of us have access to in surveillance to try to use that information to help prioritize your next interventions. The other thing that we use our data for is to systematically expand contact investigations. And we do this, this is just to summarize the steps that we take when we know that we want to go into a school or a work site and we're going to have to do sort of a large-scale contact investigation. We identify a lead epidemiologist or a lead investigator, and we create and update an outbreak summary in Maven. It's just our data system, describing the site and the exposure. Then we write an alert of the investigation, which goes all the way up to our Commissioner of Health to just make sure that our agency is aware, our press office is aware. And then we go into the site. We contact the site. We work with their administration to obtain a list of people at the site. We schedule an initial meeting, and then we go to the site to do an education session to coordinate, and then we set up coordinating testing at that site. We then use the data that we get after the screening to assess transmission, and if we see any evidence of transmission, then we may need to expand. We update all of this information in our system and generate a final report, which we call an EPI2. So I think that this systematic approach has worked really well for us for many, many years. And just to give you a flavor of how much of this is going on, in 2014, we had 413 congregate setting exposures in New York City. And you can see in a variety, in a variety of types of sites. Of the 413 exposure sites that we identified, we ended up investigating 225. 159 were healthcare worker settings where the hospitals are usually doing their own investigation and we're consulting. We did 17 large investigations, large site investigations, and 44 small site investigations, and then 5 other. But in a given year, we test anywhere from 900 to 1,000 people in these many, many investigations. So I hope that provided a reasonable summary of some of the ways that epidemiology can be used, or is used in our setting and can be used in other settings. I'm really excited about hearing about a lot of the other talks, because I think a lot of the other talks are going to provide similar kinds of examples. We're going to see the epidemiology of what is going on in the Caribbean, which I'm very excited about. You saw in our graph we have a lot of countries in the Caribbean that are contributing to the burden of disease in New York City. Then we're going to hear about outbreak and field investigations and how they're done, and I can't see the rest of my stuff, so that's it. Anyway, I'm very excited to hear the rest of the day. Thank you, everybody, for your attention.
Thank you, Shava. Dr. Brendan Bain is one of the pioneers of clinical infectious disease practice in the Caribbean, where he has worked as a physician, teacher, and researcher for more than 30 years. Professor Bain trained in medicine at the University of the West Indies in Jamaica, received an MPH degree, summa cum laude, from Boston University School of Public Health. Between 2003 and 2015, he directed the Regional Coordinating Unit of the Caribbean HIV/AIDS Regional Training Network, which was responsible for training over 20,000 healthcare workers from more than 20 Caribbean countries and territories in aspects of HIV prevention, care, and treatment. Dr. Bain will talk to us next.
Good afternoon, and thanks to the organizers for inviting me to be part of today's panel. This is a sneak preview of my slides because we go back to the beginning. Sorry about that. This is where I want to start. I think you heard that right at the beginning. So here's a brief outline of the presentation. I want to talk a little bit about the geography and politics of the Caribbean, particularly for persons who have only spent brief holidays in a particular place and don't know the broad picture, then I will spend a few minutes on the descriptive epidemiology of tuberculosis in the Caribbean, prospects for eliminating autochthonous TB in the Caribbean, and a summary at the end. Upon completion of this training, participants will be able to identify 3 mainland countries which are considered part of the Caribbean, discuss the strengths and limitations of epidemiological data from our countries, and explain how health system strengthening could benefit epidemiological practice and improve patient outcomes in the Caribbean. So, a bird's eye view. The Caribbean is a multi-ethnic and multilingual part of the world, and the letters on this screen show the main languages of business, but don't let you know that in several countries there are multiple languages themselves. So E for English, S for Spanish, F for French, and D for Dutch. And I have in the inset 3 mainland countries, Guyana, Suriname, and French Guiana, which consider themselves part of the Caribbean, and up on the left of the slide, Belize, which also is linked with several of the Caribbean islands. In terms of geography and politics, there are 40 million people in 29 nations, and several others, and 3 large countries population-wise, and many tiny dependent territories, much population movement, including migration to North America. Cuba and the Dominican Republic are often listed as part of Latin America, although they are situated in the Caribbean, and Puerto Rico is linked with the US. I think you saw that on an earlier slide, although we know that they're part of the Caribbean. Most English-speaking countries belong to the Caribbean Economic Community, and Suriname has the opportunity of belonging to both CARICOM and UNASUR. Some Francophone countries in the Caribbean are Département of France. Now to descriptive epidemiology. From data that were obtained mainly from WHO and the Pan American Health Organization. First, estimated TB incidence per 100,000 population in 2014. Haiti still heads the list, followed by Guyana and the Dominican Republic. Suriname is next, and then Belize. These are all, apart from Haiti and the Dominican Republic, countries that are based on the continents of South America, and in the case of Suriname, in the case of Belize, Central America. So you can see that the countries with the largest populations and those that are situated on land masses still have the highest estimated TB incidence, and this has been so for several years, and island countries tend to follow. I threw up this slide to show a comparison at a glance between Suriname, which isn't top of the list, and Mexico, Canada, and the United States. I put Jamaica in because I live and work there, but Jamaica doesn't feature highly in the ranking of cases of TB incidence. Look at this slide carefully, and this shows countries on the South American mainland and trends between 1990 and 2011, when the most recent data were available for doing trends. And you will see that Guyana and Suriname stand out from the rest of South America, both in terms of initial TB rates and trends. Suriname is coming down, and there'll be a presentation from a doctor from Suriname in a later part of this meeting, later this week, and he'll be able to give you more details. I think that one of the things that's helped Suriname is a grant from the Global Fund to fight AIDS, TB, and malaria, which has helped them to do effective work. I put this slide in to show the trends in the US and Canada, but I want you to look at the y-axis, and you'll see that the actual case rates are low compared with case rates here in Guyana and Suriname. And this slide also shows the general pattern in the Caribbean compared with North America. And again, look at the case rates in the Caribbean, roughly 10 times those at the start in 1990, 10 times that of North America. And the Caribbean graph is coming down ever so gently, whereas the North American graph is coming down more substantially. In the Caribbean, Haiti and the Dominican Republic, in terms of trends, also show themselves up compared with Cuba and all the other small island territories. And this slide just shows island countries. And again, looking at mortality, the Caribbean the graph sits up higher than that of the Andean countries in South America, the other countries in South America, Central America, and North America. This is the only slide that I have that focuses on childhood TB notification rates in 2011, and you can see that the tallest building there is the Caribbean. The new TB cases per 100,000, I apologize for the zero that's missing on that slide, are from the Caribbean. By this time, you will recognize that I'm trying to paint a picture of the Caribbean, and you might think that it's even before you started listening to me, but by now you realize that it's skewed towards certain countries. And those are the countries that need to do the most work. Those are the countries that in many cases have the greatest challenges in confronting tuberculosis. And this slide looks at MDR TB data. And on this side of the slide, I've chosen to show the population in millions. And you see that the countries with the largest populations are Haiti and the Dominican Republic, occupying the same island, Santo Domingo, and Cuba, and then Guyana, Suriname, and Belize, which happen to be mainland countries with fairly large populations for the Caribbean. In terms of notified cases, rates per 100,000 in brackets, you'll see again that Haiti and the Dominican Republic come to the top. Cuba falls a little below Guyana, Suriname, and Belize. And of those notified cases, the percentages that had sensitivity testing were very low in Haiti, and Suriname and Cuba come out highest. I think that Suriname has managed to do that because of the Global Fund grant, and Cuba has been ahead of most Caribbean countries in terms of its public health systems over the years. So one is not surprised to see that nearly 50% of notified cases of TB had susceptibility testing. And so the last column has to be interpreted with caution because the data are not really comparable. And you will see that of the 182 of nearly 16,000 cases in Haiti, 50% were laboratory confirmed, and one suspects that those were done at 1 or 2 sites in Haiti. Dominican Republic, nearly 20%. Belize, 1 of 4. Only 4 cases of the 87 received DST. Now, I think that this audience is aware and doesn't have to be told of the association between HIV and TB. And this is a quote from a paper by 2 Haitian authors, MacArthur Charles and Jean-William Pape, that really brings this to the fore. And the point that they make out of their context and also out of the African context is that TB remains a substantial cause of mortality in developing countries, despite available cure for TB. The Caribbean countries are doing pretty well in checking the HIV status of persons with TB disease, as you can see on this slide. And when we look at HIV prevalence among incident TB cases, new cases of TB in 2014, it's a fascinating picture because the countries are not the same. And it probably reflects some of the background situations with respect to HIV, TB prevalence, and the mixing of persons with HIV and those who are at risk for TB. And you can see the spread, Haiti being the lowest among the 8 countries that I chose for this slide, and compared with Belize. Very interesting, and we don't know really what's behind this variability. So this is the first slide that you saw when I was walking to the mic, because I think that this is where epidemiology has to go. Prospects for eliminating autochthonous TB in the Caribbean. And we need to use epidemiology and a systems approach. So what should we do? And how should we do it? Well, WHO has taken the lead in setting out what they call a building blocks approach for strengthening health systems. And it's easy from a theoretical point of view to study WHO's approach and to agree with it. Leadership and governance in the middle, and human resources, which talks about staffing, the workforce, strategic information, service delivery, equipment, facilities, and supplies and finances. But all of those elements require people. And that's a problem in several of our countries. It's not unique to the Caribbean. So here's something that I borrowed from the Public Health Foundation, how to build an optimal health system for TB, starting at the bottom with workforce capacity and competency, information and data systems, organization and systems capacity, surveillance, laboratory practice, case investigation, and at the top of my building, leadership management and oversight. But actually, I think that it's my opinion that leadership management and oversight should be at the base, because leadership and management help to push all the other things. I don't know what your view is of an optimal health system. But there's some good news for us in TB programs in the Caribbean. In July 2013, the Caribbean Public Health Agency, acronym CARPHA, was launched through the merger of 5 Caribbean health institutions. And there are new laboratory strengthening programs. CARPHA itself has embarked on this. CDC is helping us, mainly through its HIV window, and a non-governmental organization called the Caribbean MedLabs Foundation is finding ways to interact with governments, mainly through external grants, and they are working in partnership with the first 2 agencies that I mentioned. There are opportunities for research. For instance, the link between HIV and TB I was looking at the display of quantiferon earlier on, and I think that we should move from trying to do skin testing in immunocompromised persons to seeing what the efficacy of blood testing in persons that we suspect might have TB infection or TB disease is. Nobody has done that research to the best of my knowledge in the Caribbean so far. But there are challenges. Some of them you're probably aware of yourself. Some of them you can figure out yourself. Our situational factors. Those of you who track world news know that Haiti just changed their president, and the population is often not so happy about change and not so happy about choice, and that affects the way that life runs in a country like Haiti. The state of public health services, I think Cuba is ahead of the game in many of our countries. Variable HIV-TB program collaboration, a variable HIV-STI program collaboration, variable diabetes TB program collaboration. And then, of course, the built environment, which is stepping back a little bit in terms of a situational factor. Variations in poverty and educational levels. Barbados with almost 100% educated population and almost zero new cases of local TB compared with a country like Haiti and the Dominican Republic. And of course, there's always competition with other health issues, non-communicable diseases, and emerging infectious diseases. And the big F for finances. And there's always the debates about what proportion of money should be spent on health and what proportion of the health budget should be spent on each entity. Should there be vertical programs? Should there be collaborative programs? And that's an ongoing dialogue. So in summary, thinking first from a managerial viewpoint, the countries with the largest populations and with overcrowded cities have the highest burden of TB. A system strengthening approach is likely to help countries toward the goal of eliminating locally spawned TB. And competition with other health concerns, which is inevitable, tends to lower interest in TB, and particularly where case rates are low. Cross-program collaboration, which I favor, offers practical advantages, but that's not so easy to implement. It's easy to talk it, less easy to act it out. Thinking from an epidemiologic point of view, Caribbean data tends to get lost in global reports because of regional grouping. And we must continue to highlight TB epidemiology in the worst affected countries of the Caribbean and maintain action plans to tackle risk factors and reduce the burden of disease. Several Caribbean countries are close to eliminating TB. The risk for us is to put on blindfolds because we're nearly there. So I'm glad that I'm here representing the Caribbean and persons who may have their roots in the Caribbean or persons who for other reasons may have an interest can talk with me afterwards or do some reading on your own to maintain an interest. Thank you for including me in this program. Thank you.